Now we are going to study some clinical notes. الجاج ريفلكس هاي من الحفة الشي بحلقك تريد تزوق، شو يسموه بالعربي ما أعرف. الجاج ريفلكس what? Touching the posterior 1/3 of the tongue. This lead to gag reflex. This lead to contraction of pharynx muscles as if you want to vomit. The gag reflex is due, you know. We have said the posterior 1/3 is supplied by the glossopharyngeal nerve sensory. When you touch the stimulus passing upward to the brain and then descend through the glossopharyngeal and vagus nerves, these supply the muscles of the pharynx, and these lead to contraction of muscles of the pharynx, and as if you are going to vomit. If you remember, genioglossus muscle, we said, is the only one which protrudes the tongue. It leads to protrusion of the tongue. When this becomes paralyzed, this means that the other muscles will pull the tongue backward. This occurs when this becomes paralyzed, the tongue pass backward and press over the epiglottis and lead to closure of the laryngeal inlet, lead to suffocation, اختناق. Those patients which we give them general anesthesia, complete anesthesia, يروح عمليات بالعملية يحطوا له تخدير كامل. قبل ما يحط له التخدير الكامل يسوي له intubation، يحط له تيوب ينزل للقصبة الهوائية to the trachea and through the trachea, we call it endotracheal tube, so that this cause an anesthesia paralysis of all the muscles of the body and prevent the passage of the closure of this airways. So for anybody, when you give full anesthesia, you should do intubation inside the airways, and then you push the oxygen inside the lungs. Frenectomy, it means cutting of frenulum of the tongue. Sometimes the tongue has large frenula extending to the tip, and then the patient cannot protrude his tongue forward. This is very easily treated. Just you excise part of this frenula to make the anterior aspect of the tip of the tongue free. We have seen that the tongue is divided by the sulcus terminalis into two, anterior 2/3 and posterior 1/3, and the summit of the V-shaped sulcus is the foramen cecum. Now this is a depression from its name, foramen cecum. It means a closed foramen. This is the site of development of the thyroid gland. The thyroid gland develops from the floor of the oral cavity here of the tongue, and then descend downward as a thyroglossal duct, and then this thyroglossal duct become completely closed and degenerates. Sometimes some thyroid tissue remains at this foramen cecum, and these we call an aberrant or ectopic thyroid tissue, and these might be subjected for metaplasia because all the time there is pressure here, friction because of food intake, and might change into metaplasia and become carcinomatous cells. And sometimes remnants of this thyroglossal duct remains as cysts in the anterior median line of the neck. We call it thyroglossal cysts. Aberrant thyroid tissue at foramen cecum, these may undergo metaplasia. It means change their structure and change to malignant cells. Injury to hypoglossal nerve, it's very, very rare because the hypoglossal is deep. But if there is injury to hypoglossal nerve, this means paralysis of all muscles of one side of the tongue except the palatoglossus. And then the tongue will be deviated to the unparalyzed side during protrusion. Now, sublingual absorption of drugs This is one of the ways of giving drugs. As all we know, we usually use the drugs by swallowing. We swallow tablets, syrups, drugs. But there is another method of taking some drugs by putting the tablets in the floor of the oral cavity. In the floor of the oral cavity, once it dissolves, then there will be very rapid absorption of the drug. If it is dissolved and enter in the sublingual vein in less than a minute. This is one of the commonest drugs used, is that for use for angina pectoris. الذبحة الصدرية اللي يستخدمون الدول يسموه تجاري مالته NG-seed اسمه is nitroglycerin. NG-seed or nitroglycerin. When the patient feels pain in his chest, he puts a tablet of these nitroglycerin or NG-seed tablets just under his tongue, and this will be very rapidly absorbed and lead to relief of pain. This we call it sublingual absorption. Sublingual, it means تحت اللسان, absorption of the drugs. Lingual carcinoma, as I said, with lymphatic drainage, this might spread along the lymphatic drainage to different nodes. That of the tip spreads to the submental lymph nodes. If it is in the medial part of the anterior two-third, then might spread to the lower deep cervical lymph nodes. If it is in the lateral parts of anterior two-third, to the submandibular lymph nodes. From the posterior one-third, directly they might pass to the upper deep cervical lymph nodes. So by now we have finished with the tongue. Now, the tongue, we said, is one of the contents and mostly almost fills the oral cavity. In addition to the tongue, the oral cavity contains glands. Some are mucous glands. These are numerous and they lie very small and minute glands. They lie within the mucous membrane of the tongue. And next we have salivary glands. The salivary glands, these are again within the oral cavity. They all develop from the floor of the oral cavity or the walls of the oral cavity. Some of them remains inside the oral cavity. Some they pass outside the oral cavity while the ducts open into the oral cavity. We have two groups of salivary glands. Main salivary glands, these are large, the main salivary glands, and these we have three pairs of these glands. We have two parotids, two submandibular glands, and two sublingual glands. These are the major ones which develop from the floor of the oral cavity, the parotid and the submandibular. They pass outside the oral cavity, but the ducts remain inside to open inside the oral cavity. The sublingual remains inside the floor of the oral cavity totally. In addition, we have minor salivary glands. These are small. They lie within the mucosa. They are scattered over the palate, that's the roof, over the lips, the cheeks, the tonsils, and that over the tongue. Now, all the salivary glands, the minor and the major, they are exocrine glands. So this means they should have a duct, and through the duct, they power their secretion into the oral cavity. Structure of them, they are compound, tubulo-alveolar, so they are formed of tubule cells forming tubules, and some form alveoli. Alveoli means like حوصلة glands, and all of them, they secrete saliva. Ducts, all of them open into the oral cavity. The minor ones, these are microscopic, can be seen only by microscope, and the ducts are very, very minute. They lie within the cells of the mucous membrane of the oral cavity or the tongue or the palate or the cheeks and the lips, and they secrete small quantities of saliva. The major ones, they are large and can be palpated and seen easily, either inside or outside, and their ducts are large and can be, the openings of the ducts can be seen again in the floor, in the parts of the oral cavity. Now you will start with the major salivary glands. Or before that, as I said, they secrete saliva. And all you know, saliva is a clear, colorless fluid. It's odorless and viscous. Functions of the saliva, these are important in dentistry. In dentistry, because the saliva keeps the mucous membrane of the mouth more moist all the time, preventing it from cracking. Also lubricates food during mastication. Once you start ingestion of food, there is parasympathetic stimulation of the salivary glands, and they secrete large quantities of saliva. Even sometimes when you smell, بس تشم الأكل يبدي saliva secretion of saliva into the oral cavity. So it lubricates food during mastication and then begins digestion of starch. Digestion, starch والنشا, and digestion means هضم. This is because the saliva contains amylase enzyme. Next, the saliva serves as an intrinsic mouthwash because it contains is a fluid, so just like watery fluid, and so it washes the oral cavity. At the same time, also plays an important role in prevention of tooth decay because it contains lysosomes, which act as an antibacterial agents, and then plays an important role in the ability of test because the materials which you eat, when you test it, we said, if you remember, that the test buds cannot sensitize the food unless it is dissolved in the secretions of the oral cavity. So most of them dissolves in the saliva secretion, and then we'll be able to test the ingested food. So these are the functions of the saliva. Keeps mucous membrane moist, lubricates food during mastication, begins digestion of starch through amylase enzyme, serves as an intrinsic mouthwash, contain lysosome, playing an important role in prevention of tooth decay, and also important role in ability of test. Now we'll start with the major salivary glands. As I said, you have 3 pairs of major salivary glands. These are the parotid, the submandibular, and the sublingual salivary glands. The parotid gland is the largest of the 3 pairs. Looking to this slide, on the top left, this is a picture of the face. We have removed the auricle here, and this is the external acoustic meatus. We have removed the skin and the muscles, most of the muscles of the face, with the superficial fascia. And these are the contents of superficial fascia, the nerves and vessels. Now the parotid gland lies deep to the muscles of the face, between the deep to the superficial fascia. It has an irregular shape, but it looks like a three-sided pyramid with the base of it directed upward and the apex directed downward. So it has three surfaces. The parotid gland lies anterior to the external acoustic meatus. Anterior to the external acoustic meatus, and is applied to over the mesenteric muscle over the ramus of the mandible, and then molds on the posterior border of the ramus of the mandible posteriorly. It has 3 surfaces. The base of it reaches to below the zygomatic arch. The apex reaches toward the angle of the mandible. The parotid gland has no true capsule because it develops from the epithelium of the floor of the walls of the oral cavity protrudes outside and pushes itself between the structures in the face. But it's covered, the parotid gland, by a layer from deep investing layer of cervical fascia. This whitish membrane is the investing layer of deep cervical fascia, which ascends from the neck, become attached to the base of the mandible and to the angle of the mandible here, reaching to the parotid gland. It splits into two layers and enclose the parotid gland to form a false capsule for the parotid gland. And then passing over the superior border, the two layers fuse and attach to the zygomatic arch. So the capsule, here the investing layer of deep fascia become thickened from the angle of the mandible, passing toward the styloid process behind the external acoustic meatus. Then comes to the thyroid. This thickened portion we call stylomandibular ligament. Coming to the parotid, it splits into two layers to enclose the parotid gland, and then the two layers fuse at the upper surface border of the parotid and fuse to the zygomatic arch, forming a capsule for the parotid gland. As I said, the parotid has three surfaces: an outer or superficial surface here. The superficial surface is covered with of the skin superficial fascia. In superficial fascia. And then we come to the investing layer of deep cervical fascia. Two other surfaces are anteromedial. The anteromedial, this lies over the muscle. The posteromedial, this molds the posterior border of the radius of the mandible and lies just lateral to the temporomandibular joint, and anterior to the auricle. Now, the parotid gland, since it develops from the protrusion of the oral cavity, and as I said, has no true capsule. Has no true capsule. So, as it protrudes, it makes itself between other structures. These structures are situated within the gland, within the parts of the gland, but have nothing to do with the gland. These we call them intraglandular structures. It means inside the gland, but they are non-glandular. They are not involved in the secretion of the saliva or the part of the gland itself. These are intraglandular, and presence of these structures inside the gland make surgery on the parotid gland very difficult, because you might enter these non-glandular structures within the parotid gland. Now, these we call them collectively non-glandular structures or intraglandular structures. They lie within the parotid. Here on the top right, we have removed the deep fascia from it, and then we have removed the portion of the parotid gland to see these structures inside the gland, sometimes emerging from the upper border, some from the anterior border, some from the lower border, but all lie within this parotid gland. You have removed the portion of the gland to see these structures in this part. Now, the structures which are non-glandular and pass inside the gland, we have nerves. First, we have the auriculotemporal nerve. This is the auriculotemporal nerve. This nerve emerges from the mandibular and enters inside behind the ramus of the mandible, inside the parotid gland, and then emerges anterior to the auricle from below the parotid gland, ascend to supply the skin of the temple. So this is one nerve passing inside the parotid gland. Next, we have the facial nerve, which you have seen supplying the muscles of the face. Here, the facial nerve As it emerges from stylomastoid foramen, it gives its posterior auricular branch here and then enters inside the gland. We have removed the portion of the gland to see the facial nerve inside it. Here within the parotid gland, the facial nerve then divides into its terminal 5 branches, which emerge from the borders of the parotid gland. Here you have the temporal branch, the temporal branch of the facial. Then you have the zygomatic branch of the facial, the buccal branch of the facial, and then you have the marginal mandibular of the facial and the cervical branch of the facial. You have studied these 5 branches with the supply of the muscles of the face. They supply the muscles of facial expression. So the facial nerve, stem, and division into terminal branches all lie within the parotid gland. So these are the 2 nerves which lie within the parotid. Auriculotemporal and facial nerve. This is for the nerves within the gland. Now next we have arteries within the gland. Now the artery within the gland is the external carotid artery. The external carotid artery here is the external carotid artery in this section. Now this artery continues after giving the facial and the lingual branch, continues still behind the angle of the mandible. And from there, it enters inside the parotid gland. Inside the parotid gland, it divides into 2 terminal branches. It divides into superficial temporal artery, which is this one, emerging from the upper border together with the auriculotemporal nerve, with the superficial temporal vein, pass within the gland and descend upward. So you have maxillary artery entering inside deeply on posteromedial surface of the gland, and the superficial temporal as one of the terminal branch of it. The other terminal branch of external carotid, which lies again deep inside the gland, is the maxillary artery. This is a branch of the maxillary artery inside the parotid gland. Again, this is the superficial temporal artery. So we have 3 arteries. Yeah. So we have the external carotid with its 2 terminal branches dividing inside the gland into superficial temporal and maxillary artery, which passes deep here inside the infratemporal fossa. The superficial temporal emerges from its superior border, accompanies the auriculotemporal nerve. This is for the arteries. Now veins accompanies the arteries. Again, enters within the parotid gland. We have the superficial temporal, which accompanies superficial temporal artery, draining all its tributaries, enters inside the gland. This unites within the gland. Within the gland, the superficial temporal artery within the gland unites with the pterygoid plexus and maxillary vein, forming retromandibular vein. Now the retromandibular vein is formed inside the parotid gland from the union of superficial temporal vein and the maxillary vein. Then this vein is short and completely lies within the parotid, and within the parotid gland divides into 2 branches which emerge from the parotid gland. From below the parotid gland, it divides into posterior division and anterior division. The posterior division here emerge from the posterior aspect. This is the posterior division again. This joins emerge from below parotid and joins the retroauricular or posterior auricular vein. Retroauricular or posterior auricular vein here is the same retroauricular vein. The two join with each other and form the external jugular vein, which is a superficial vein, descend on the sternocleidomastoid muscle of the neck. The anterior division of it emerges from below the anterior pole of the parotid gland and join with this facial vein, and form common facial vein. With the facial, this is the anterior division of retromandibular vein. Again, anterior division of retromandibular vein emerging from below the parotid gland. So you have superficial temporal vein, termination of maxillary vein, retromandibular vein within it, and anterior and posterior divisions of retromandibular vein all lie within the parotid gland. So, in addition to the arteries, veins, and the nerves, within the parotid gland also lies two to three lymph nodes. We call them deep parotid lymph nodes. And superficial to this fascia lies also 2 to 3 superficial parotid lymph nodes, or are called preauricular lymph nodes. So the non-glandular structures within the gland, by now we have two nerves. We have two nerves, auriculotemporal and facial nerves. Arteries, we have external carotid, superficial temporal, maxillary. Veins, superficial temporal, maxillary, retromandibular, anterior and posterior divisions of retromandibular vein. In addition, we have the deep parotid lymph nodes. All these we call non-glandular structures, but they are intraglandular. They lie within the gland. So assume all these structures of this gland, inside this gland, you need to operate on the gland, and then you might injure the facial nerve, auriculotemporal nerve, or any branch of these. You might injure the veins or the arteries. Now, the parotid gland, as I said, is an exocrine gland, so it has a duct. The duct of the parotid gland emerges from the anterior border of it, middle of the anterior border, it's about 5 centimeters in length, passes over the buccinator muscle here. You see, this is the duct of it, over the masseter, and then over the buccinator muscle for a short distance, then pierces the buccinator muscle and opens into the vestibule of the oral cavity on the summit of a conical papilla at the opposite upper second molar teeth. If you look to inside of the cheek, you can see the small parotid papillae, and on the summit of it, there is the opening of the parotid duct. The parotid duct is accompanied, related to it by the buccal branch of the facial nerve, buccal branch, and sometimes the buccal branch of the mandibular nerve. Lies over the masseter face and then over the buccinator muscle and then pierces the buccinator. Sometimes there is some alveoli of the parotid gland lying over the middle of the parotid duct. Sometimes are present. Not all the people have these, but this is accessory parotid gland, and the ducts of these alveoli are also inside the main parotid duct. Now, the blood supply of the parotid duct is, of course, from the branch of the superficial temporal artery and the external carotid and maxillary, which gives glandular branch for the parotid gland. The venous drainage is into the retromandibular vein. The nerve supply of it, sensory is by the branch of the trigeminal nerve, the auriculotemporal nerve. iris, and then post-ganglionic parasympathetic fibers. Parasympathetic fibers come from the otic ganglia, again carried by the otic ganglia lies in the infratemporal fossa, and the post-ganglionic parasympathetic fibers are carried by the auriculotemporal nerve, leaving the nerve as it enters inside the parotid gland, supply the alveoli of the gland. It's secretomotor for the gland, means that it increases secretion of the saliva from the parotid gland. Sympathetic supply, which decreases the secretion of saliva, is inhibitory for the gland. This comes from the superior cervical sympathetic ganglia along plexus around the external carotid artery. Lymph drainage is to the parotid lymph nodes. So parotid again is largest of the three pairs, has an irregular shape, occupies gap between the styloid process, has no capsule, but enclosed by deep investing layer of cervical fascia with a thickened stylomandibular ligament separating it from the submandibular gland. It projects over the masseter, small or detached part, as I said, sometimes might lie above its duct. It's composed of only entirely serous glandular tissue, serous secretion of the parotid gland. As I said, it's like an inverted three-sided pyramid having a small superior, superficial, anteromedial, and posteromedial surface, and the apex is directed downward. Superior surface or base is related to the cartilaginous part of external costic meatus below the zygomatic arch and posterior aspect of TM joint, with the auriculotemporal nerve curves around neck of the mandible to enter inside the gland. The apex overlaps posterior belly of digastric. Superficial surface is covered with the skin. Superficial fascia containing branch of auriculotemporal nerve, the superficial parotid nodes, and then we have the investing layer of deep cervical fascia. Anteromedial, grooved by posterior border of ramus, covers part of masseter and lateral aspect of TMJ. Posteromedial, molded to mastoid process, sternocleidomastoid, and posterior belly of digastric and styloid process. As muscles and is grooved by external carotid, which enters inside the gland again. Intraglandular structures, these traverse the gland partly or wholly. Vessels, we have external carotid terminating inside it, dividing into maxillary and superficial temporal artery, posterior artery, posterior auricular, maxillary vein, superficial temporal vein to unite to form retromandibular vein and divides into anterior and posterior divisions within the gland. Nerves, auriculotemporal, facial, and its terminal branch emerging from its anterior border, deep parotid lymph nodes embedded inside it. Parotid duct, 5 centimeters long, 3 millimeters diameter, begins by confluence of two main tributaries within the gland, with an anterior part crosses masseter and then at its anterior border curves medially at almost right angles, traversing buccal pad of fat and buccinator, and then runs for a short distance in buccinator and oral mucosa to open a small papilla opposite upper second molar tooth. Relations, buccal branch of facial nerve lies above and below it, accessory gland, transverse facial artery lies above it, and sometimes buccal branch of mandibular is just below the anterior border. Blood supply, glandular branch from external carotid, superficial temporal, veins drain to the retromandibular and external jugular, lymph to the parotid nodes, and from there to the upper deep cervical nodes. Some sympathetic supply from external carotid plexus, inhibitory, parasympathetic from otic ganglia, secretomotor, and sensory auriculotemporal.